introduce two Navy colleagues who have been teaching the fundamentals of critical care medicine course to many, many people in the U.S. Navy, the corpsmen, so that when they deploy, they have some basics of knowledge, since they may be in an isolated setting, which our ACSs have turned out to be. So I'd like to introduce Dr. Scott Parrish, who is the former head of the ICU at Balboa Naval Hospital, and Captain Ryan Maves, who is head of infectious disease and is a board certified infectious disease and critical care physician. Both are highly accomplished and have CVs that are a mile long. I don't know who would like to go first. They're going to talk to us about two things that aren't in the FCCS course, which is COVID management, and then a hands-on or just a conversation about how does it just set up a ventilator if everything kind of hits the fan and we're surging out. So Scott, Ryan, welcome. You are being recorded, and we'll plan to share this with other teammates who couldn't attend today. We have over, I think, 75, 80 who have signed up for the FCCS course.
I'm happy to start, unless Scott, do you want to go? I'm ready to go.
Okay, terrific, Ryan.
All right, hey, so good morning, everyone. Thank you to Dr. Devereaux for the introduction. I'm Ryan Maves. I'm a critical care and infectious disease physician here in San Diego. And I'm going to talk, this is going to be a little more kind of science-y than a lot of FCCS is, and then I'm going to talk about kind of how we treat COVID. For those of you who don't have a lot of experience with directly managing these patients in an acute care setting, and you know, I've had the good/bad fortune to take care of quite a bit of this, not nearly as much as some of our friends in other parts of the country, but so what we do is kind of go over like the evidence base. So and I think the reason we're going to do it this way is so that people have a chance to kind of understand why it is this way and not another way. So I'm going to share my screen in a second if I can get the blessing. And I see that from, there we go. Perfect. All right, here we go. And all right. Can everyone see my screen? That work?
Yes.
All right, great. All right, so I'm going to talk about kind of the medical management of this, and then Dr. Parrish will talk about the ventilator management and the non-specific support that we would do for any critically ill patient with respiratory or cardiovascular failure. So again, I'm Ryan Maves, critical care and ID. I'm in my last year of active duty, so I'm actually now the former head of ID. I'm the former head of a lot of things around here now. Okay, great. So just standard disclaimers. No one pays me to do this. I am an investigator in one of the clinical trials we'll be talking about, so there's a modest amount of bias. And of course, anything I say here is my opinion and not the opinion of my employer. All right, so I think one thing that comes up a lot in FCCS, and those of us who are involved in acute care and critical care in general appreciate that there are two sort of competing schools of thought in critical care. So one competing school of thought is what I call the Fabergé egg model of critical care, where each patient is a individually, beautifully crafted, completely unique entity, right? Where our approach to every patient is entirely individualized and highly based on the individual skill of the clinicians caring for the patient, right? The other school of thought is what is the Model T, on the heavily protocolized model, where we treat all ARDS the same, and we manage septic shock in a predictable and repeatable manner. Both of these schools of thought are useful, and I think another expression that's useful in this setting is that all models are wrong, but some models are useful, meaning that having a general standardized protocolized manner to manage patients, especially when you're dealing with large numbers of patients, and especially dealing with some large numbers of patients with a problem that may be new to you, improves care and improves outcomes. And that's not to say there isn't room for individualized management. Of course there is. But having a framework, having a cognitive framework said, if patients meet these criteria, I do this. Most of this happens unconsciously. But for many people, again, this is a new disease, and I think it's useful to at least have that framework in mind. All right. This is just a gentle reminder to everyone. This is not the first time human society has gone through this. This is a picture from the 1918 Spanish influenza pandemic, controversies about mask wearing, controversies about social distancing. None of this is new. None of this is new. We have lived through this before. We will live through this again. That doesn't mean that it doesn't come with a horrible human cost. And thank you all for volunteering to do this work. There's also to say that there is a fair amount of evidence out there to guide our therapy. Early in the coronavirus pandemic, there was a lot of, I don't know what you want to call it, sorcery, shall we call it? A lot of enthusiasm for therapies that were based on extremely flimsy evidence, 15 patient case series, stuff like that. So this was an early paper saying that, hey, if we just are good doctors and nurses and respiratory therapists, we can take care of the majority of these patients well. This was a report came out in Clinical Infectious Diseases, one of our main journal. It's authored by the guy on the right. I'm the bald guy on the left in this picture. This is out in the Amazon. This is by one of my former fellows, Derek Larson, who works out in Virginia now. That evidence-based care works. So let's take a look at, see just kind of what our, what do we know about drugs that decrease mortality in COVID-19? So lopinavir, ritonavir is an older antiretroviral. There's a lot of enthusiasm for it earlier. Short answer is it doesn't work. Umifenavir and favipiravir are anti-influenza drugs that are licensed mostly in Asia or in Russia. Favi is actually a pretty good flu drug, but it doesn't appear to have any obvious evidence on standard of care. It may have a role in outpatients. Remdesivir's impact on mortality is uncertain. I'm just going to leave it at that. It's uncertain. I think it has a good role in care, and we'll talk about that. Tocilizumab, a lot of excitement for that drug early in the pandemic. There is no good supporting data. There is a manuscript out from a very reputable clinical trials group that is suggesting that there is a benefit. I think that I've got to see the full paper before I change this slide. Convalescent plasma is unproven, and I would say it is actually right now largely refuted as an effective intervention in hospitalized patients. Then corticosteroids work, right? Steroids work, and there is good evidence for decreased mortality with that. All right, so I update this slide every time I give a version of this talk. As of last night, there were 1,600 interventional trials for COVID-19 that are active, recruited, or completed on clinicaltrials.gov, which is where clinical trials get registered, of which about a third are in the US, about another third are in Europe and the UK, and the rest are sort of spread around the world. And that is not counting trials that are only registered in the European or Chinese registries as well. So military expression, the bottom line up front, like what's the bottom line and how we're going to medically manage these patients. This is again separate from their specific critical care support, such as ventilatory management and oxygen and treatment of shock and such. So the first thing is protect yourself, right? Infection prevention precautions. We generally favor enhanced contact precautions with either an N95, PAPR, or CAPR for respiratory protection for patients with suspected or confirmed COVID-19, right? And I'll say that Dr. Devereaux and Dr. Parrish and I have a couple of very good friends and colleagues who are contending with this right now, who've been taking care of a lot of COVID along the way. And so this stuff is very, very real. So focusing on the basics, so rigorous attention to infection prevention and staff safety, low tidal volume ventilation, which Dr. Parrish will discuss with you in a moment. DVT prophylaxis. So this is a thing that we have to really sort out here, but you'll read a lot of stuff, and I'm not going to go into enormous detail about this, but basically the short answer is standard DVT prophylaxis for patients, meaning some variant of usually enoxaparin or Lovenox, 40 milligrams once a day or 30 milligrams twice a day, with a lot of vigilance for clinical clot. There have been a lot of people considering should we like fully anticoagulate all of these patients, or at least all the ones with respiratory failure. The data does not support that right now, and most professional societies are saying some variant of standard DVT prophylaxis. Then obviously volume status and hemodynamic management. From a medical management standpoint, for patients who are hypoxemic, meaning room air sats of less than 94%, the current standard of care is if they're not on the vent, That is, if they're not intubated, not on the ventilator, 5 days of remdesivir, and we'll talk about that. Maybe 10 days in selected patients, but generally 5 days of remdesivir in patients who are not intubated. If someone's on the vent, then the benefits of remdesivir are pretty limited at that point. One quick second. I have to adjust something here. All right, and then for patients with hypoxemia, also administration of dexamethasone, 6 milligrams daily. That can be oral or that can be IV. That is for up to 10 days or until they're discharged from the hospital, right? Once they're dischargeable from the hospital, you don't have to continue either remdesivir or dexamethasone. You don't keep them in the hospital to finish their 5 days of remdesivir if they're ready to go. And again, Dex can be oral. There are some other potentially useful agents, but right now that is the standard of care. Dex in everyone who's hypoxemic, remdesivir in patients who are hypoxemic but not on the vent. Once someone is sick enough to be on the ventilator, the benefit of remdesivir appears to go away. And the NIH guidelines are actually updated like 2 days ago to reflect that. Monoclonal antibodies, there's been a lot of attention in the news about this. These are, pharmaceutically prepared antibodies directed against COVID, against SARS-CoV-2. They may have a role in high-risk outpatients. And we'll look at the kind of clinical data behind that. But in the hospitalized patient, they do not have any benefit, and I do not advocate their use. And the FDA authorization for these drugs explicitly says that. So things like convalescent plasma, higher dose anticoagulation, these are investigational. These are currently unconfirmed therapies. I'm not saying you never do them. I'm just saying we have to be intellectually honest about what we're doing in this case. All right, so antiviral. So remdesivir, this is what remdesivir looks like. It's a viral RNA polymerase inhibitor. There's a lot of ongoing clinical trials. I have had the good luck to be involved in a couple of those. Gilead, who's a manufacturer of them, it is now FDA approved. It goes by the trade name of Veklury. I'm going to level with you outside of this talk. I've never heard anyone say Veklury out loud. Everyone just calls it remdesivir. If any of you practice HIV medicine, Gilead makes a lot of HIV drugs, and Veklury is a very Gilead trade name. Their drugs are named like Biktarvy and Odefsey and things like that. So first trial of remdesivir was done in Wuhan in China at the very beginning of the pandemic. It was 237 patients. They were all about 65 years old on average. More men were in the placebo group. It was a largely male group. People were getting a lot of other stuff at the same time, antiretrovirals, interferons, glucocorticoids. Not too many of them were on the vent. The end of the outbreak officially in Wuhan meant that this trial was stopped early, which meant that this study was underpowered. It wasn't able to detect any real difference between groups. But interestingly, what they did see was that people who got remdesivir, they seemed to be on the vent less. They seemed to come off a ventilator faster, 42 days in the placebo group, 19 days in the remdesivir group. So that's kind of interesting. And it seemed like more people were improved 1 month out from their acute illness who got remdesivir compared with placebo. These weren't significant, but it was interesting, right? It was interesting. It looked like it did something. And remdesivir has been around for a while. It was actually studied as a drug for Ebola. It treats a lot of RNA viruses. And so people were able to start doing trials with remdesivir very, very early on because at least we already had safety data for it, because remdesivir had been used in large-scale human phase 3 trials before the COVID-19 pandemic began. And so at least we kind of knew how it worked, and it had been used in people who were critically ill. So that meant we could just kind of start, right? So this led, at the same time as the study in Wuhan was started, the NIH, the National Institutes of Allergy and Infectious Diseases, the group headed by Dr. Fauci, started this thing called the Adaptive COVID-19 Treatment Trial, or the ACT. This is an ongoing, the ACT is ongoing, although this version is over. So this first study was a study of 1,000 patients who got randomized to either remdesivir or placebo. This was done at 68 hospitals around the world, most of them in the US. The primary outcome in this study is time to clinical improvement. This is meaning patients who are hospitalized. So when we define clinical improvement in this study, it means you fit into one of three categories. So you're either hospitalized still, but you weren't really requiring any medical care. And so an example of this would be someone who was still hospitalized early in the pandemic because they kept having a positive PCR for COVID, and that people thought that meant they couldn't leave the hospital. And so it'd be people who were stuck in the hospital for infection control reasons and not for their own like acute illness. So we'd count them as clinically improved. Or if they're able to go home, but if they still felt kind of lousy, maybe they needed a couple liters of supplemental O2 at home, but they were home, they're out of the hospital. Then the third category would be people who were fine, who were able to go back home and had no real limitations on activity. So if you started off sicker and then you moved into one of these three categories, you're considered to be clinically improved, and that's the primary outcome of this study. So this trial enrolled very fast, completed enrollment in April. It had a data safety monitoring board evaluation about a week after the study closed. And then finally, full analysis, what it showed is that people who got remdesivir got better faster. I'll go and talk about what it actually showed. So this is the trial results of this. And again, I am one of the investigators on this study, so I can probably talk about it till your ears fall off. So if you have any questions, let me know. But the bottom line is that people who got remdesivir got better faster, meaning that people who got placebo who were hospitalized with COVID-19, if you got placebo, it took you 15 days to get better. If you got remdesivir, it took you 10 days to get better, right? So it shaved 5 days off of your recovery time. These curves here on the, let's see here, is this the pointer? All right, great. Can you see my little pointer thing here, guys?
Yes.
Okay, great. So this is the overall group, and you can see the blue line are people who got remdesivir, the red line are people who got placebo, and the people who got remdesivir recovered a bit faster. But then you kind of look and see how sick were they, and this is a practical thing, and the reason I'm going over this in sort of agonizing detail is because this affects how you manage patients on the ground. So people who did not require any supplemental oxygen, who are not hypoxemic, this is the upper right-hand corner, there is no real difference between remdesivir and placebo. These patients generally do pretty well and generally recover, and adding remdesivir does not really significantly make them better any faster. You know, maybe modestly better, but you can see those curves are pretty close to each other. Now, if someone required supplemental oxygen, that is, they're on anywhere from 1 to 15 liters per minute by nasal cannula or a simple face mask, those people got better significantly faster with remdesivir, and that's where most of the benefit is in people who were requiring supplemental oxygen up to about 15 liters per minute. People who required more advanced forms of respiratory support that Dr. Parrish will describe in greater detail, that is people receiving high flow nasal cannula, so anywhere from, so greater than 15 liters per minute, up to 100% FiO2, or receiving non-invasive mechanical ventilation. You know, remdesivir folks seem to get better a little faster, but by about 3 weeks, it all evened out. So the benefit there was not particularly marked. And when you look at people who are on the vent or on ECMO, there's no difference, right? Getting placebo or getting remdesivir, you got better at the same pace. And as you can see by the proportion recovered, not very quickly. And I think this reflects what a lot of us have seen clinically. You've got patients who've been on the ventilator for weeks, and our very sickest patients are very slow to recover. And this is important because the specific COVID therapies become less important the further down the road you go. And really what you're just doing after that is practicing good critical care, volume management, ventilator management, prevention of complications. There is evidence of a mortality reduction, but it is not statistically significant except the supplemental O2 group. And probably what this means, and this is the upper left-hand corner here, is if people got remdesivir, we are preventing deterioration, right? So if you're sick enough to get remdesivir, you have pneumonia, you're hypoxemic, you give them remdesivir and they don't deteriorate as often, and this leads to a mortality benefit. If you're on high flow in the upper right or on the vent, lower left, there is no real difference. And so the takeaway message from all of this, if people who are hypoxic, remdesivir helps. People who are on high flow, it's okay to give it. The guidelines still say it's a reasonable intervention. There may still be some benefit, but we have to be realistic about what it's going to do. But if they're on the ventilator and we recognize that we have this scarce resource, remdesivir availability is not that bad, but nonetheless, it is expensive and there isn't enough of it to go around. There are 100,000 patients hospitalized in the United States with COVID right now. Patients on the vent do not benefit, and your conscience is clear by not giving it to intubated patients. But patients who are on the ward, patients who are on high flow, it is reasonable to give it. All right, so that's good, right? Remdesivir works, we're done. Well, there was another study that kind of threw a wrench into the works here. And this just came out, it was published, or published isn't the word, it was released as a preprint about a month and a half ago, but just came out in the New England Journal online this week. And this is called the Solidarity Trial. And this was a trial of 11,000 people done in 30 countries, 405 hospitals, sponsored by the World Health Organization. And they randomized people to get the local standard of care, whatever that might be, the local standard of care, to versus either remdesivir, hydroxychloroquine, lopinavir, ritonavir, interferon, or what have you. So this is called a pragmatic trial. They just compare people to whatever the local standard of care was. Their Kaplan-Meier, their mortality in the study is about 12%. If you're already on the vent, it was about 39% at the time of randomization, right? So that's a pretty high mortality. And this is what they reported, that they saw no difference in mortality with remdesivir, and also no difference in time to clinical improvement with remdesivir compared with placebo, right? So I'm just telling you, I still advocate for remdesivir. So let's talk about why, because this has been in the news. And I think a lot of people who are kind of work in COVID adjacent fields are aware of this. I actually have had to put out a couple fires related to this along the way. This is their, it's called a forest plot, where they kind of show how people do in terms of time to mortality and time to recovery between the two studies. We'll skip that. This is the problem with this study. There is no placebo arm. There is no blinding of this study. There's no data monitoring. And I can say, I've got 3 randomized controlled trials going right now that I'm the site PI for. And I have data monitors coming and poring over my data laboriously, line by line, every week, right? To make sure that the data is reliable and accurate. So very limited data monitoring. There's no diagnostic confirmation. We don't know how long people were sick. We don't know how sick they were when they got there. And then there's this widespread in different healthcare capacities status of different sites. And actually, it's funny, the Iranian Society of Critical Care Medicine wrote a letter to the editor saying, because a lot of the remdesivir data came from Iran, and they said that their data should be thrown out from the Solidarity Trial because it was no good, which is interesting to note that. I don't want to make this seem like it's a bad study. I think what it means is that in places where there are marked resource limitations, not just like the resource limitations that you will all face with an overburdened healthcare system in California, but if you are practicing in Iran, if you are practicing in South America, if you're practicing in Peru, where I used to work and live, if you have a limited amount of resources and you are struggling just to maintain the ability to provide adequate oxygenation, adequate nutrition, DVT prophylaxis, all of that, that maybe remdesivir is not worth your time, that maybe the incremental benefit of remdesivir is not worth it. I think that's probably the takeaway. In a relatively homogeneous setting, the kinds of places where the NIH studies have been done and continue to go on, these trials are continuing, where you have something approximating a contemporary industrialized country standard of care. Remdesivir, shaving 5 days off of a time of hospitalization is a big deal. Shaving 5 days off. That is a thing that will help, one of many things that will help decompress an overwhelmed healthcare system, gets people home faster. Mortality benefit is maybe not that marked, but it still means something. Getting people home faster matters. And so I still advocate for remdesivir, and the NIH guidelines in the United States still advocate for that as well, for that very reason. So there are some other antiviral drugs that I've mentioned. There are, which so far none are proven, but we'll see if that changes. Interferons. Interferons are a group of drugs that are used for a wide variety of things. They're immunomodulators. We just finished a trial of remdesivir plus or minus interferon beta for the treatment of severe COVID. That data is, I still don't know the results of that study because it ended like 2 days ago. So we'll see if that helps or not. There was no benefit to interference in the Solidarity trial, though. So I don't think that will be a thing you folks will wind up using, but just so you know, that is a potential intervention. There's some small studies that suggest there might be some benefit. Going forward, that might be something we add adjunctively to the care of folks with COVID-19. But again, I actually don't know the results of the study yet. So I'll let you know when I find out. All right, immunomodulating agents. So things that kind of tamp down you'll hear the term cytokine storm a lot in reference to severe COVID. So there was an observation early in the pandemic that there is this syndrome that looks like, it's called hemophagocytic lymphohistiocytosis, or HLH, or like a thing called a cytokine release syndrome, which resembled a form of critical illness seen in patients who received a certain form of therapy for leukemia and lymphoma called CAR T-cell therapy. And these patients would have very high levels of interleukin-6 and very high levels of ferritin in their blood. They thought, well, it looks kind of like HLH or CRS, so let's treat it like HLH or CRS. And that's with these two drugs, tocilizumab and sirolimus, which are different manufacturers, but basically the same thing. The manufacturers of these drugs took these drugs in severe COVID all the way to phase 3, but terminated both their studies due to lack of evidence of benefit in critically ill patients. So right now, these are not recommended. I will say there is a preprint floating around there from a very reputable international clinical trial group called the REMAP-CAP group, which suggests that there may be a benefit. That paper's not out yet. Maybe this will change, but right now I'd say don't exert a lot of psychic energy on trying to get people tocilizumab or sirolimus. Convalescent plasma. So this is widely available. There are a number of health systems, including in San Diego, that use these. The idea is you take plasma with antibodies from people who've recovered from COVID, right? And you give it to people with COVID and you see if they get better. So this is a thing that people have done for a number of other infectious diseases. I'm seeing if there's anything in the chat. Oh, why the strange image of a strange person who hovering on the speaker? That's me, by the way. That's my own, it's a video of myself. I put that in because I thought it was funny and I forgot that was the video I was using. I apologize. I mostly do that to creep out my residents when I'm giving them talks. So convalescent plasma. So there are a number of things that convalescent plasma is used for, right? So prior uses include for Argentine hemorrhagic fever, for Ebola, for influenza. I will say that the only diseases that convalescent plasma really has proof of efficacy for is actually Argentine hemorrhagic fever and maybe diphtheria. We actually participated in a trial of convalescent plasma for influenza a couple years ago, and that was a negative study. But that being said, right, we do what we can. There were a couple small case series out of Asia looking at convalescent plasma in the treatment of severe COVID-19. It seemed like people maybe got a little better, but these are like 5 patients, 10 patients. This is from that. I'll just kind of skip that to say. So the Mayo Clinic started this massive nationwide emergency access protocol for convalescent plasma. And over 40, 50,000 patients in the United States have now received this therapy. One of the challenges of this is that this probably inhibited us doing a trial of this, right? Because this is a good example in COVID where our enthusiasm for a concept outstripped the data. There is a kind of a preprint out there of what they did. 35,000 patients, over half obese, about 18%, 19% were African-American, about 38% were Latino. So this actually reflects approximately the epidemiology of severe COVID-19 in the United States. High prevalence of obesity, as well as a lot of people of color. About 30% of them got remdesivir, about half of them got steroids. And what they showed was that people who got, because plasma is not all the same, right? It's not a purified product. It's not something you get from a lab or from a factory. It's what you pull out of the human body. So some people have what we call high titer plasma, meaning they have a lot of antibodies against COVID, and some people have low titer plasma, meaning they only have a lesser amount of antibodies against SARS-CoV-2. And then some people got, because this is all observational data, some people got convalescent plasma early, some people got it later. And so what they did is they said, listen, the people who got convalescent plasma less than 3 days or less, from symptom onset did better than people who got it more than 4 days after symptom onset. And people who got high titer plasma did better than people who got low titer plasma. So that suggests a dose response, that people who got therapy earlier and people who got high titers seem to do a bit better. All right, so that's suggestive. That's hypothesis generating, and suggests there may be a benefit to convalescent plasma. The flip side of that, though, is that it could mean that just giving plasma late is harmful and giving plasma early is neutral and has no benefit, right? So this is one of the problems of the sort of like observational data, is that there's too many confounding factors to do it. So we kind of staggered along, but actually in the last few weeks, there has been a pretty good, reasonably sized randomized trial of convalescent plasma. The Mayo protocol made it very difficult to do a randomized trial of this in the United States. So this study was actually done in Argentina, but it's a good study. And essentially what they found is that there was no real difference in the two interventions. The same proportion of patients died, the same proportion of patients needed a ventilator, same proportion of people needed supplemental oxygen, the same proportion of people were discharged home. And in fact, more people who got placebo were discharged home early, although it wasn't significant, or were discharged with full return to baseline. So it does not appear at this point that convalescent plasma is terribly effective. That's not to say that other bigger trials couldn't be done to study this in greater detail. But then you get into steroids, right? So I'll tell you, when this all began and people were advocating giving glucocorticoids to patients with severe COVID, you know, I'm a critical care doctor, but I'm also an infectious disease doctor. And the idea of giving steroids for viral pneumonia strikes me as insane, right? It's like treating a forest fire with kerosene. It sounds bonkers to me. And there is some data from H1N1, from our last great respiratory pandemic, that suggests just that those patients did worse. So, you know, but, you know, if COVID teaches us anything, it's to be humble in what we think we know until it is proven, until it's actually been demonstrated. So, you know, steroids had been recommended up until then just for vasopressor-resistant shock. There was some early Chinese data. This is from JAMA Internal Medicine, 84 patients with acute respiratory distress syndrome. And it looked like patients who got Solumedrol, who got methylprednisolone, did better. Again, observational, small study, but hypothesis generating. So then the recovery trial came out. This was done in the UK. Big study, 6,400 patients, of whom a third received dexamethasone versus the then standard of care. Now, very little remdesivir was used in this study. It was done very early in the pandemic, and remdesivir wasn't widely available, so only 5 patients got it. One of the things about the recovery trial that makes it hard to interpret is that there was an extremely high baseline mortality. So 26% of the people who were not on the ventilator died. So that is a jaw-droppingly high baseline mortality rate. And it makes it a little tricky to interpret just what all of it means. But the bottom line, again, I'm going to focus on patients here. So this was all participants. And you see here the usual care arm, this was their mortality. The dexamethasone arm, this was their mortality. That it seemed like people who got dex died less often, and that was statistically significant. But who were the ones who benefited? Patients who were on the vent had a marked reduction in mortality. You know, again, about a 40% mortality. That is higher than our observed mortality in the United States right now, but it's not radically different. That is a big gap. And so dexamethasone very rapidly became accepted as a standard of care. Now, there's some limitations in the recovery trial as well, including the fact that it was an unblinded open label study that limits some of it, but mortality is a pretty hard endpoint. So it's pretty hard to like blind someone from death. Oxygen only, patients who are just receiving nasal cannula or something like that, there is a difference, but it's relatively small. And this is interesting. People who are not requiring supplemental oxygen, there is no difference. And if anything, the dexamethasone group seemed to do a little worse. But again, this is a very high baseline mortality. Right? 15% of people who didn't require supplemental oxygen died in this study. So these are people who we wouldn't even necessarily admit. So again, it makes it a little challenging to interpret, but the takeaway of this, if someone is hypoxemic, that is SATs less than 94% on room air, they seem to benefit from dexamethasone, and that benefit is greatest in people on the vent. So the indications are very similar to that of remdesivir, but the group that benefits is different. Remdesivir, it's really kind of this group, the people who are on 1 to 15 liters per minute of supplemental O2. they get most of the bang for their buck from remdesivir. The group who is on the ventilator gets most of the bang for their buck from dexamethasone. So supplemental oxygen, high flow, non-invasive, we would give them remdesivir and dex, both. Invasive mechanical ventilation, they really only benefit from dexamethasone, and remdesivir is no longer necessary. Patients who are not hypoxemic, they do not require either of those. And if anything, there is a signal for harm with dexamethasone if that person has a normal sat on room air. Any questions about that? Okay, this is just a forest plot of that data showing that all patients kind of collectively seem to benefit, but the non-hypoxemic patients, not so much. So WHO did a meta-analysis of, because the recovery trial came out, there were a bunch of other steroid studies going on at the same time. I point this out just because it is possible that you'll be in a setting where there may be drug shortages. And it's worthwhile taking a look at this. You say, well, okay, the study was done on dexamethasone. What about other steroids? Could I use hydrocortisone? Could I use solumedrol? And the short version is yes. There's all these other steroid studies that were going on simultaneously with recovery. They all got terminated early because the recovery trial results were considered to be so strong that it would be considered unethical to continue randomizing people to no steroids in those studies. But they did report their interim analyses. And the bottom line is it seems that hydrocortisone or methylprednisolone or probably prednisone would all be like acceptable as an alternative. So I tend to use Dex, but if I was out of Dex, would I give solumedrol to someone or I give prednisone to someone? Yeah, I totally would, and that would be fine. All right, so monoclonal antibodies. Dr. Devereaux asked me to bring this up, and just to say that this is I will be completely candid with you that I am wrestling with how to use this right now, because clearly there's a group of people who benefit from monoclonals. I am trying to figure out how to get this very limited resource, much more limited than remdesivir and certainly more than dexamethasone, to the right folks. And so there have been a few studies of this. One is the ACTIV-3 trial. This is a randomized trial of bamlanivimab, which is one of the monoclonals, for hospitalized patients with COVID. This trial was terminated due to futility. So people who are being hospitalized, there's no role for monoclonals. It seems the role of monoclonals is to prevent outpatients from getting sick enough to be admitted, right? So the BLAZE-1 trial was published in the New England Journal, and this was in high-risk outpatients. And just to kind of summarize what it showed, people who got placebo, 6.3% of them went on to require hospitalization. People who got some dose of bamlanivimab, still working on that one, got hospitalized much less, 1.6%. And that seems to be real. There's some dose finding and figuring out what the ideal dose of this agent is. The challenge is figuring out who benefits from it and what's the safest way to administer it. And that is logistically a bit complex because it's about a 3-hour total time to administer this agent between the actual infusion, the setup, the getting the line, monitoring after the infusion is complete, infection prevention during the infusion. Like at my hospital, our infusion center is in the cancer clinic. I can't very well put someone with an active COVID infection in there next to all the chemotherapy patients. So there are logistical hurdles to making this work, and then identifying what people are most likely to benefit. The expanded the emergency use authorization for these drugs, suggest patients above a certain age, patients with diabetes, with chronic cardiac or pulmonary disease, obesity. Well, that becomes a lot of people. That becomes a lot of people with COVID, and figuring out just who the ideal patients to administer this to is a little bit tricky. And I will say that is probably a question that goes beyond the scope of FCCS. But just to say there is evidence of benefit in high-risk outpatients, and figuring out how to operationalize this is one of the challenges, and really one of the big, but it goes back down to the basics of scarce resource allocation, where we look at, like any kind of triage setting, right? We want to find people, we want to identify people who are too sick to benefit from this therapy, too healthy to benefit from this therapy, and the people who are exactly right to benefit from this therapy. So we're giving it to the right people to reduce morbidity and mortality. There are a lot of other drugs out there. Just to mention that they exist. Baricitinib, this was a drug we studied in ACT 2, the second iteration of the ACT trial. We have evidence of benefit for baricitinib. That paper is not yet published. It's been accepted by the New England Journal. I will say that there seems to be a subgroup of people. Baricitinib is a rheumatoid arthritis drug. It seems to help, again, beyond the scope of this discussion. We are going to be comparing it to dexamethasone in a subsequent randomized trial that I hope will begin next week. Eculizumab is a nightmarish drug that may have some benefit, but I've given eculizumab for other things and it's a huge pain in the butt, so I don't recommend it. So, summary, drug therapy for COVID-19. Dexamethasone and remdesivir for patients with hypoxemia. Remdesivir is probably better given earlier rather than later. And if you're intubated, there's probably no point in remdesivir. I'd say this, if you're started on remdesivir and then you go on to be intubated, it's reasonable to at least complete the course of remdesivir. That's probably fine. I wouldn't necessarily turn it off when people get intubated. There is a role for convalescent plasma, maybe, probably safe, but the randomized trial data does not support it right now. Immunomodulators other than steroids, like interferon, like baricitinib, that's a work in progress. I would say for our purposes of your deployment and your public service, I would not worry about those too much. Your answer is dexamethasone. Monoclonal antibodies for high-risk outpatients, they have a role, and like I said, that needs to be worked out. But really the personal appeal is like, what has brought our mortality down for hospitalized patients with COVID-19? It ain't remdesivir, maybe some of it's dexamethasone, it's the basics, right? It is practicing good medicine, good nursing care, good RT work. Low tidal volume ventilation, hemodynamic management, prevention of thrombosis, nutrition, those are the things. Master the basics first. We get that done, then everything else will take care of itself. This is me. It's in my plague doctor mask on the left. Up there's a sign, just again reminding us of the Spanish influenza in a century ago. This is not the first time we've been through this. Thank you for the opportunity to speak to you today. Stay safe. My email address is down there if you got any questions or concerns. And I think I have a few minutes for questions before Dr. Parrish has to go. Appreciate it, guys.
Thank you, Ryan. This is excellent. I've been receiving texts from the participants that are telling me that they really are learning a lot. I'd like to open it up to the floor for any questions you have for Ryan, and then I'll bring up some questions of my own. Maybe everybody's just saturated. Oh, here's something from Dr. Zhang. So you mentioned to start early. What about somebody who's 10 days out after testing positive?
Yeah, that's a great question. So, and thank you for it. Right. So I think from a practical standpoint, you start it when you start it, right? I mean, meaning starting it, patients who receive it earlier probably do a little better, but I will admit that in ACT 1, there was a subset analysis looking at patients who had 10 days of symptoms versus 10 days or more of symptoms versus 10 days or less of symptoms. And there didn't appear to be a real difference, that the benefit didn't seem to differ that much. There are some other smaller studies that suggested there would be a benefit. I would say this, our decision to start remdesivir is based on physiologic status, not necessarily on duration of symptoms. If someone becomes newly hypoxemic more than 10 days out, I think you have more of a differential diagnosis for the reason for their hypoxemia, and one would be pulmonary embolus, which is very common, and that would be about the timeline when we would expect to see that. So I think at that point, you need to at least be exploring the possibility that the problem is not SARS-CoV-2 replication per se, but maybe another cause. But the short answer is, even though in large populations, the benefit is likely greatest in earlier infection, if someone shows up 10 days out from symptom onset, now newly hypoxemic with COVID, and they don't have like a PE or something to explain their hypoxemia, I would still start remdesivir in that setting.
Question, Ryan. Can you hear me?
Yeah.
Tom Cromwell, this is more of an ethical question than a therapeutic question, and most or many of the people that we have in our medical reserve corps and CALMAT and things of that sort are over 65 and therefore in the at-risk group. Do
Right.
we or should we ethically deploy these people into a situation where they're clearly going to get involved with COVID patients?
Well, I will start by being evasive, saying that is not necessarily a decision that I'm fully qualified to tell you. I will tell you this. I think PPE works. And I think if you have an adequate supply of PPE and you are trained in its use and you are using it carefully and judiciously, that the risk to the individual clinician is very low. And my impression is, with a handful of exceptions, the great majority of people in my line of work, I'm thinking of one notable exception, who have acquired COVID, acquired it in the community and not at work. So from that standpoint, believing that believing that PPE at work is an effective preventive strategy against COVID, then yes, I think it is ethical. But I think that is also a decision to be made by the individual. That is, if you have an adequate supply of PPE for those folks who are at an increased risk, and they are willing to assume the small but non-zero risk with appropriate PPE, then yes, I think it's fine. But I think that has to be an informed decision by the individual. And I think that presupposes available of adequate PPE and adequate training. In the absence of those things, then I don't think it's ethical for any of us to be there, except as pure humanitarians. But your work is also not a suicide pact.
Well, it is a problematic question because, you know, even fire camps, you could be exposed to COVID patients. So it's virtually anything we could deploy people on. So it is a problem. And I guess one thought is to have them sign some sort of a consent form, knowing that they are aware of the threat. However, many of the people in all of these groups are very, very interested in deploying, and I'm not sure that's even an adequate answer.
Well, I mean, a consent form assumes that you're trying to shield yourself from legal liability, right?
Right.
And I am not an attorney. And I couldn't tell you much about that. But I would say, if your volunteers have been adequately trained, adequately supplied, and adequately informed, if they are willing to accept that risk as individuals, and God bless them. And I'm proud to know them.
Thank you.
Thank you, sir.
And Ryan, Dr. Baines, you have a question?
Yes, I had a question. First of all, thank you for the presentation. It's very informational. How about, let's say you did mention patients do better on high flow with the remdesivir and the DEXA, correct?
Yeah, so patients on high flow, we saw, some patients on, 20 liters per minute or more, FiO2s of 40% or greater. Those folks may have a small benefit from remdesivir, but they have a pretty good benefit from Dex. I would give them both, and that is what the current NIH guidelines advocate.
Okay.
But, in times of, I would say this, in times of, if you're like running out of remdesivir,
yeah,
you're probably not hurting people on high flow or non-invasive ventilation to not give them remdesivir.
If we have a patient that deteriorates and requires to be put on the vent, what would your recommendation would be if they were on the tube before?
If they're already on the tube, definitely continue the dexamethasone.
Okay.
And then the question becomes, do you continue the remdesivir? And that becomes a judgment call. And the data is not consistent in who would benefit. There was a thing called the SIMPLE trial, which was industry-sponsored and open label, that suggested that they should continue the drug for 10 days. That has not been replicated elsewhere.
Okay.
So I think at that point it becomes a question of clinician judgment, and I don't think you're going to do any harm with either decision.
Okay.
I have generally, my own personal practice has been just letting him finish the 5 days of remdesivir, because at that point, whatever. But I'm going to be honest with you, I'm not sure I'm doing a ton of good with that.
Okay. And then also in terms of like chest physiotherapy or any other methods that can be used, have you seen anything that can be done in addition to this to kind of help with that ventilation of the lung?
Well, proning and awake proning.
That,
right?
of course,
And
yeah.
Dr. Parrish will talk about that in great detail. I mean, we would do standard stuff. You know, chest physiotherapy gets to be a little bit tricky because it is an aerosolizing procedure. If your RTs are properly PPE'd up and you're doing it in a negative pressure room, then I think that's perfectly acceptable. We just have to acknowledge that that is a thing. But in bed proning, you know, we are still waiting for randomized data and such to demonstrate efficacy. But observationally, I think we've all been impressed with how well that works. Doesn't work in everybody, but it does seem to buy us some time.
Thank you so much.
Thank you.
So Ryan, while you were talking, and I apologize for this, but I figured it gives folks a chance to be familiar with a set of ACS orders that we worked on last week for Imperial County. And because many of you may be deploying shortly, so it's good for you to know that we spent a lot of time kind of testing this order set out. We are using paper charts in the alternate care sites. So just FYI to Ryan and Scott, who remember those days. And so we created this order set, and we have much of what Dr. Maves have talked about, including the DVT prophylaxis. And we did have to put in some for the BMI increase.
Yeah, and that's very wise. And we are, you know, this actually came up when I was rounding in the unit last weekend, where we had some people with some fairly impressive BMIs, and deciding kind of what approach we were going to take, and appreciating there's a wide spectrum of good practice here. The BMI greater than 50, 60 BID of enoxaparin is something I did just a few days ago. Yeah, it's not a lot of data for it, but I think this is a good moment to appreciate, like this, the thing I've described, the medical management thing is giving all of us a framework by which to practice. But DVT prophylaxis is a great example of there being a spectrum of good practice, and the rubric that Dr. Devereaux has presented here is definitely, you know, solidly in that domain, where like we haven't validated every component of that, but all of it's pretty reasonable, and everyone in critical care who looks at that would be like, okay, yeah, that makes sense, right?
Thank you for that blessing as well.
Asha has literally never needed my approval, and will, but always has it, for what it's worth.
Thank you. So, and I'm sure I appreciate your email, and if there's any other questions, please email me and I'll forward them to Dr. Maves, or you guys can email him directly. And thanks for this excellent talk, Ryan.
Well, thank you so much. And I have to apologize, I will have to log off for Dr. Parrish's talk because I'm on call and I got to go around. So, but thank you so much for the opportunity to speak to you, and thanks to all of you for volunteering to do this. It's like I said, I'm honored and humbled to have the chance to speak to you today.
We really appreciate it. Thank you.
Thank you.
Lots of people are clapping for you right now. Thanks, Ryan. And
Okay.
with that, we'll segue to Dr. Parrish. Dr. Maves talked a lot about oxygen and support. And part of the FCCS course is kind of a hands-on ventilator section, but we're not doing group learning. So Dr. Parrish, if you'd like to talk to us a little bit more about that, and I think we'll have lots of questions at the end for you as well.
All right, let's see if I can figure this out. I'm a little bit of a novice with this.
So there's a little green box at the bottom that says share screen. There you go.
All right, you got that? Do you see that?
Yes, it looks great.
Okay, great. Yeah, Ryan did an excellent job talking about the science of many of the therapeutics for COVID. My talk is, I think, much different. It's going to be just focused on much of the on several basic concepts with the critical care management of patients with COVID, specifically those that pertain to the oxygenation, ventilation of those patients. He did make a lot of good points. He did promise a lot of things I would talk about, which I'm not sure how much depth I'll talk about each of those items. But one of the most important things when you talk about critical care, I think, is it's really, really good outcomes or brilliance in the basics. It's making sure you avoid complications, that you do the basic things right, and that you do them well. And I think that is always very important. Brilliance in the basics when you look at these things. I am currently I was active duty for a number of years. Then I retired, sort of, into the same job, and I continue to work full time at the Naval Medical Center. I've also had the opportunity to travel quite a bit, working in other countries. Probably almost 2 years of time spent in the last 15 years in other countries working. Many of those countries much more resource poor than the United States. Let's get that out of there. So one thing about infection control that I think is important, almost everything we do in the ICU is a potential problem with infection control, and certainly with COVID-19. A lot of our medical procedures, intubation, extubation, sputum induction, high flow oxygen, all those things do present problems with aerosolized air from the patient. And certainly we're always concerned about spreading COVID through improper PPE. And I think in our unit in the last 6-7 months, we've done a great job wearing PPE for all these procedures. So far in our unit, I don't think we've had any patient to staff transmissions in our unit. When you look at supportive treatment for COVID, if I back off 1 second, just say right now I'm the ICU attending and I have one of my colleagues covering for me for the next couple hours, but we have a few patients with COVID in our unit, not too many, but there are 6 up there right now with COVID. They vary quite a bit in their ages, although they do tend to be in the older age group. All of our patients, all 6 of them are not intubated at present. They're all on high flow oxygen at this point, which has become very common. I think at the beginning of the pandemic, many of the patients in our unit right now who are on high flow nasal cannula, those patients would have been intubated. But I think we learned early on that these patients can tolerate marginal O2 sats, 88 to 92, 94% well with the high flow nasal cannula, and they have good outcomes with that. There are many potential problems with intubating a patient. If it's done well, if you have a good ventilator, if you have good support staff, and you're very careful about avoiding volutrauma, barotrauma, and things like that, then a mechanical ventilator is life-saving and very helpful. If you have a lot of people who don't know how to use the mechanical ventilators well, then you can cause a lot of harm with mechanical ventilation that's poorly done. So I think many of those issues with mechanical ventilation in high utilization areas like New York early on showed the problems with mechanical ventilation, and it showed the potential advantages of aggressive high flow nasal cannula for many of these marginal patients. We do use supplemental oxygen. We do very quickly go to high flow nasal cannula. And in a moment, I'll show a slide that kind of breaks down the different types of oxygen support therapies available for our patients. But in general, the high flow nasal cannula, many of the benefits historically have been shown with high flows in the 40 liter plus range. You know, the 10, 20, 30 per minute flow rates, they certainly help people. They certainly help oxygenate people. But when you look at mortality benefits, it's best demonstrated for those people with the highest flows. There's a lot of concern about non-invasive positive pressure ventilation for our hypoxemic COVID patients. There's a lot of concern about aerosol spread. We do use non-invasive positive pressure ventilation. I think maybe about 10% of patients who are on high flow have a high work of breathing, and because of that high work of breathing, or they also have things like COPD with bronchospasm and things like that, I think that group of patients has responded well to BiPAP, non-invasive ventilation, where they get pressure through a mask at 2 different levels. And those patients have done well, but we certainly are concerned about spread of COVID with that therapy. Fortunately, all our rooms are negative pressure, and certainly we wear full PPE whenever we go in for those patients. So we do consider non-invasive positive pressure ventilation. We do use it for a select group of patients. And then things that generate a high aerosol rates like nebulizers we avoid. So we really have switched to metered dose inhalers. Before COVID, we knew well that metered dose inhalers, if properly used, were equivalent to nebulizers. However, nebulizers are relatively easy to use by staff, and many of our patients were getting nebulized treatments. But by and large, all our COVID patients get metered dose inhalers when they need something for bronchodilation. I've not seen any of them get nebulized treatment. Corticosteroids, we obviously dragged our feet quite a bit on early on because of evidence from previous viral pandemics and epidemics and experience. We know that people who are on high-dose steroids or who are on any steroids, it actually prolongs the viral shedding. That having been said, the dexamethasone data is compelling. And all of our patients in the unit who require oxygen, with very few exceptions, do get dexamethasone. All our patients up there today are on dexamethasone. And I think it is the single most important medication that we provide our patients in the unit. The DVT, Ryan mentioned some things on prophylaxis for venous thrombosis. It is a big problem for patients. If you look across a lot of autopsy series from New York and a lot of experience, the rate of PEs and DVTs are much higher in patients who have COVID infection. And even we've seen patients who we've sent home from the hospital who come back a few weeks later with a PE or DVT. So prophylaxis for our patients is very important. And then we do know that some of our patients become very hypercoagulable. There is a subgroup of COVID patients who will have an elevated level of just their PTT alone, and that often can represent what we call an antiphospholipid antibody syndrome or lupus anticoagulant, and those people tend to clot a lot. And so some patients who have an elevated PTT will go above their prophylaxis dose of heparin or low molecular weight heparin, and we'll actually give them a treatment dose. And then also selected patients who have hypoxemic respiratory failure, who have very high D-dimers and very high, who look like they have DIC. Those patients also will consider giving them treatment doses of heparin to prevent them from developing worsening respiratory failure due to thromboembolic disease. The data is really out on that, and the professional societies do give a little bit of conflicting recommendations, or they just don't have firm recommendations on how to manage that. But that's kind of our practice, that almost everyone gets prophylaxis for DVTs and PEs, and then some of our patients actually get treatment levels. And then I'll come back to the prone positioning in a couple minutes briefly, but prone positioning is extremely important. Just yesterday, we had a patient who was being presented for admission to the ICU, and the patient was in our emergency room and very high need for supplemental oxygen. And our beds were full in the ICU, but we went down to the ER, we proned that patient, and just after a short while of proning, we got that patient off their high flow nasal cannula down to just a lower level of supplemental oxygen, and we were able to safely send that patient to the ward. So prone positioning very quickly can improve outcomes. And then our long-term data with things like the acute respiratory distress syndrome and things like, and diseases like that, have shown us that if you can prone a patient for 14, 16 hours or more a day, those patients actually have improved outcomes. So we really have found prone positioning on intubated and also non-intubated patients to be very helpful. Now, this is like everything about oxygen delivery devices in one page. The ACP website for COVID-19 therapy has this group of one-page things on mechanical ventilation, which you'll see in a moment. and acid-base balance and oxygen delivery devices. But this guy, Nick Mark, has come up with these one-page guidelines. And this kind of summarizes a lot of our nasal oxygen delivery devices that we have available. So you can see on the far left, the conventional nasal cannula generally gives up to about 6 liters a minute. And the flow with the FiO2, you can get it up to about 45% oxygen. Now that's for a medical student breathing comfortably that you do blood gases on, that you can get up to 45%. If someone's tachypnic and they have a very high minute ventilation and you're giving them supplemental oxygen at 6 liters a minute, they can draw in 40, 50, 60 liters a minute of air. So they're really starting training just pure room air with just a little bit of the supplemental oxygen. So in real life, if someone has a very high respiratory rate and a very high demand and they're on nasal cannula, you'll never get an FiO2 of 45% to that patient. You'll get an FiO2 maybe as low as 26 or 27% to that. So it does depend on their respiratory rate. Now you could do things to offset that increased ventilation for that particular patient by adding reservoirs. So you have a 200 or 300 cc reservoir in the system, so that as the patient starts drawing in air at 20, 30, 40 liters a minute, they'll draw in basically a pure plug of oxygen from that reservoir. And that can allow you to maintain and to achieve a higher FiO2. Now for people who have a very tachypnic, very high flow rate, then the high flow nasal cannula are key. And those systems are a little more complicated than just plugging into the wall and shooting oxygen out at a high rate. You have to humidify the air and you have to have the potential to warm the air also, so that you don't dry out the patient's respiratory tract with that high flow. Many of our patients find it somewhat uncomfortable, but many patients are very comfortable. When I came down to give these talks, I had at least 2 patients up there who were eating on high flow oxygen, and they were comfortable enough to eat and maintain their sats. For these patients, they were in their high 80s while they were eating, so they actually did okay. The high flow oxygen delivers a lot of oxygen, and it also gives you a little bit of pressure, and that pressure is transmitted down the airway. And you could find studies that show that your alveoli see 2 centimeters of pressure, 3 centimeters of pressure, 4 centimeters of pressure from that high flow system. And that pressure helps prevent those alveoli from collapsing. When the alveoli collapse down, then blood goes through that collapsed down portion of the lung, but there's no oxygenation or ventilation to that area. And that's shunt. And so that contributes to hypoxemia a lot, this shunt, this atelectasis. And the high flow systems can help prevent that atelectasis shunt. And it really is peak down in the airways. So the high flow nasal cannula has been very important. But you do need a system set up. I know yesterday we were kind of stressed with the system, with what we had available, and we had run out of our high flow systems, which was a little bit problematic because then it meant that for patients who needed the high flow and things, we had to non-invasively ventilate them with BiPAP or just traditional non-invasive ventilation. So you can get a limitation of equipment with the high flow, but we do use it fairly often. And again, all our patients in the ICU right now are on the high flow systems. Okay. Now, when you look at some general guidelines, I brought these up. I have 3 of these. So again, these are the NIH guidelines. They're pretty good to go to. And if you have questions about, if you hear about something being approved and you want to know the status of it, if you just go to the NIH website, the COVID-19 treatment guidelines, within hours to a day or two, those guidelines get updated to reflect the body of evidence supporting or going against specific treatments. So this kind of digs down a little bit more into the recommendations, some of the things I talked about. It talks about the nasal cannula, it talks about the high flow systems, and then it talks about intubation. I'll come back to intubation briefly on another slide and kind of cover a few points about that. And then the thing to remember, if someone really needs intubation, which I have a slide a little bit later on, that's not the patient that you really want to do high flow on and things like that. You just need to intubate those patients. Patients who need intubation, as I'll come back to, those are patients who are in respiratory distress, who are have secondary organ dysfunction due to hypoxemia. their work of breathing is very high, they have altered mental status. Those are patients who should be intubated and not just kept on their non-invasive ventilation. Now, proning is key. So we've proned a lot of patients. I think months and months ago, we learned that taking patients who are not intubated and proning them is very helpful. I know of patients who are not in our ICU, but who are on the wards. They're being successfully proned while they're on high flow systems or nasal cannula. And that's allowing them to avoid coming to the unit. It's allowing them to safely avoid intubation also. So ARDS, acute respiratory distress syndrome, pneumonias, certainly COVID pneumonias, it's an asymmetric disease. You'll have patchy involvement of the lungs. You often have posteriorly a lot more disease than anteriorly. And then the way your diaphragm sits, that if you take a patient who's supine and you prone them, you'll shift the blood flow in the lungs to areas of the lung that are better oxygenated, better ventilated, and you'll improve ventilation perfusion mismatch, and you'll improve oxygenation. And it's pretty significant. It's pretty noticeable when you prone these patients. So all of our patients, we attempt to prone. Many patients have back pain. They have shoulder pain. We had a patient with recent breast surgery who had difficulty proning. So I'll say that you don't need to prone them face down, but many patients, if you can get them up on their side, leaning semi-prone, but at an angle, you'll see benefit also. And so we have one gentleman up there with back pain. He just kind of goes left to right, and he's angled downward, largely prone, but not truly prone position, but he just switched to sides regularly, and that helps a lot. But the longer you can prone them a day, the better. You certainly should try to prone them at least 12 hours a day, and then ideally 16 hours a day or more proning is best for this group of patients. We prone patients who are on non-invasive ventilation. We prone all our patients who are ventilated that we can, and then we certainly prone patients who are on lower levels of supplemental oxygen support. Now, intubating a patient with COVID is challenging. In one of our groups a couple months ago, international group we were on, one of the docs from Toronto, he said he just finished a week in the unit. He said the first day in the unit, he was intubating patients, that by the third, fourth, fifth, sixth day in the unit, he was not intubating at all. And he said typically he would leave a patient, the patient was doing fine, they were satting 88, 90, 90%, not intubated. And he'd shift over, and he said the anesthesiologist or the fellow at night would come in and intubate the patient. But many patients do well without intubation. You have to look at the patient and judge individually what is best for that patient. These are patients who a year ago we would have intubated. These are patients that if they had sepsis or things other than COVID, I would intubate very quickly. So someone whose oxygen level is 88, 87, 89%, who has sepsis, I would intubate that patient. Those patients tend to have very poor outcomes. They tend to have a lot of more cardiac irritability, a lot more dysrhythmias, and they have a lot more secondary organ dysfunction. The COVID group of patients, when we were rounding this morning, we were talking about why they seem to do just fine with 88, 90% SATs, 91% SATs not intubated. And a lot of them, they're this happy hypoxemic type patient. Their lungs don't seem to be as heavy. Their VQ matching, for whatever reason, doesn't seem to be as bad. Their work of breathing doesn't seem to be as bad. And so even though their oxygen level is low or low normal, they're physiologically over their whole body, their acid-base balance is good, and they're really not stressed that much. But you have to really look at these patients. Obviously, if someone is in the 85, 86% SAT range, and that's the best they are, or they have worsening hypercarbia while they're on maximum non-invasive therapies, then we'll intubate those patients. Any altered mental status interferes greatly with the ability to non-invasively oxygenate that patient. We'll certainly intubate those patients. Respiratory distress is kind of a looking at them, their work or breathing, their vital signs. That will get them intubated. And then coexisting organ dysfunction, if they have cardiac dysrhythmias, if they have making cardiac enzymes, if they have any other evidence of other organ dysfunction, then we'll intubate that group of patients. Obviously, intubating this group of patients is very nerve-wracking. They're very hypoxemic. Some of the lowest oxygen levels you'll ever see are patients that you intubate. We tend to intubate them very quickly. Normally, in a non-COVID patient, you'll get them set up to intubate. You'll pre-oxygenate them well. You'll, if you're going to do a rapid sequence intubation, you'll sedate them, then you'll paralyze them. You'll continue to bag them for a little bit to make sure they're pre-oxygenated well, and then you'll intubate the patient. You'll do a glide scope or direct laryngoscope, and you'll intubate that patient. With COVID patients, because of infection control issues and because of their severity of the hypoxemia, you'll typically do it very rapidly. You'll pre-oxygenate the person as best you can, either on their high flow system or non-invasive ventilation. Then you'll give them rapid sequence intubation. You typically will not bag them at all, and then you'll just proceed right to intubation for that patient. Obviously, with their low oxygen levels, that's a major potential for adverse outcomes can happen when you intubate those patients. Now, when you look at these patients, if you did the FCCS course covers, I look up on my bookshelf here and I have a couple textbooks on mechanical ventilation. They're 2,000-3,000 pages long. Chapters in my critical care textbooks are hundreds of pages devoted to mechanical ventilation. The fundamental critical care support course devotes 2 lectures to mechanical ventilation plus a couple skills stations on it. So mechanical ventilation can be very, very complicated, but there are some basics that we should talk about. Now, for the last 20 plus years, we've really focused on low tidal volume ventilation for many of our patients who have stiff non-compliant lungs that you see from pneumonia, that you see from COVID, that you see from the acute respiratory distress syndrome. I think when I started out in medicine in the late 80s, it was more typical to ventilate patients with tidal volumes of 10, 11, 12 cc's per kilogram of their ideal body weight. In the last 20 years, we've really shifted to lower tidal volumes. So this is 4 to 6 cc's per kilogram of tidal volume of their ideal body weight. So just because you eat a lot of pizza and you've achieved a lifetime body weight of 300-400 pounds doesn't mean your lungs get any bigger. It's your ideal body weight that you really need to focus on when you look at 4 to 6 cc's per kilogram. And by using these lower tidal volumes, we give less barotrauma to the lung. So every time you push a slug of air down into the lung, you open and close the airways. There's a lot of pressure on each of those hinge points where you open and close the airways. There's a lot of potential trauma to the basement membranes. You can get a lot of fracture, and that's barotrauma or volutrauma. With the lower tidal volumes, we've learned that we cause less ongoing injury. So low tidal volume ventilation is the standard for all our patients. And then if you look at how much pressure to give to the lung, if you push a volume breath into the lung and at the end of inhalation, you just hold that breath, you'll get a relatively reasonable measure of how compliant the lung is. And if you push too much air in, you'll get very high plateau pressures. Obviously, if you push too little air in, you'll get a high CO2 and you won't ventilate the patient adequately. But we know that for almost every condition that a patient gets intubated for, if you keep their plateau pressures less than 30, so that means you push the air in and then you just pause the ventilator for a quarter second or a half a second and you measure the pressure. If you keep that pressure less than 30 centimeters, then you'll give your patient the best chance of survival. So that recommendation carries into almost every medical condition we treat. And certainly for COVID, the NIH panel recommends targeting a plateau pressure of less than 30. So low tidal volume, plateau pressures less than 30. And then this last statement, the panel recommends using a conservative fluid strategy over a liberal fluid strategy. I think that's very important. So when you volume resuscitate a patient who's in shock or who's in distress in the ER or on admission to the hospital, we typically for sepsis will give 20 to 30 cc's per kilogram of body weight. So you'll give a patient 2, 3, 4, 5, 6 liters of fluid very quickly. Now, with many lung conditions, including COVID, you have a lot of capillary leak. That fluid will spill over into the lungs. It will contribute to the pulmonary edema, and it will contribute to your difficulty. It will contribute to your difficulty oxygenating those patients. And so there have been studies out for other conditions in the last 5-10 years that have showed that if you're a little more conservative with your fluids, maybe give the patient 1 liter or 2 liters and go earlier on to pressors, things like dopamine and Levophed, pressors to get your pressure up adequately. So a little less fluid, a little more early use of pressors, you'll have better outcomes for those patients. So I think COVID is a good example of a patient that you want to kind of keep neutral. So we resuscitate a patient, they may end up a liter or 2 positive that day. And then if they're hemodynamic supported, certainly 24, 36, 48 hours into their ICU course, we've shifted them over to a conservative strategy, and we're trying to diurese them, or we're at least trying to keep them net even to barely net negative. And we're leaning on pressors a little bit to get the blood, the pressures we want. So conservative fluid strategy, I think, is real. I think it's helpful. So the low tidal volume, the plateau pressures, the conservative fluid strategies. Now, high PEEP, when you look at PEEP, so you push a volume of air in or pressure of air into the lung for a volume for a certain amount of time, and that ventilates the patient, and then you allow them to exhale. PEEP is a positive end to expiratory pressure. We keep a pressure on the lung throughout the ventilatory cycle. A long, long time ago, before we used PEEP, you would let the pressure go down to almost 0. And when the pressure gets very low, the lung that's heavy and wet will collapse. And then the next breath that goes in will have to open up, push that small airways open again. And there's a lot of volutrauma potential with that. There are many other reasons to keep the PEEP up. It helps prevent atelectasis. It helps with oxygenation. So there's low PEEP. Almost every patient we intubate and ventilate is on 5 of PEEP as a standard. The higher PEEP strategies would be that a patient with COVID or with ARDS would be on 12, 13, 14 centimeters of pressure throughout their ventilatory cycle. And I think generally all the patients that I've ventilated with COVID in the last few months, generally their PEEPs are 10, 11, 12, or 13. That's kind of a normal range. And those patients probably have better outcomes. It certainly has not been studied in detail with COVID, but you'd have to look to other studies in the past. And then proning, you really want to prone as much as you can, 12 hours a day at a minimum, but certainly shoot for 16 hours or more a day would be good. Now, here's that thing I promised from earlier where the oxygen therapy, the guy got all on one sheet, but this Nick Mark got a lot of stuff on mechanical ventilation on this one page, and it's pretty good. When you look at mechanical ventilation, companies, there are a lot of competing companies that make mechanical ventilators. A lot of companies have patented certain terms so that when a new company comes out on the market building a ventilator and they have a similar mode of ventilation, they have to come up with a different term. But there's this core group of modes of mechanical ventilation there are, and then it's kind of clouded over by all the trademarked and patented names, which I think someone had published an article about a year ago that said there were about 300 different names for the different modes of ventilation. But these are some of the modes commonly used. Volume control, almost every ventilator does that. It's one of the oldest things that we've had. It works well. You have to watch your peak pressures. You have to watch your plateau pressures. But it is very helpful. And if you look over on the far right, that major settings example, the two things in green, if you have someone in volume control ventilation and you're trying to adjust their pH or their CO2, then you would go to those green things. You would adjust their respiratory rate and their tidal volume to improve your ventilation. If you have that same patient in volume control ventilation and you're trying to change their oxygenation, then the things in blue, the PEEP and the FiO2, are what you'd focus on first to try to improve their oxygenation. Below the volume control ventilation, you see pressure control. So pressure control ventilation is where you take an inspiratory breath for the patient, and that breath is made up of, you increase the pressure and you apply that pressure for a certain amount of time, the volume delivered to the patient then becomes variable, and it depends on how compliant the patient is, how awake the patient, how much the patient's working to assist that breath. But it's a set pressure for a certain amount of time, achieves a volume which can vary a little bit. Now over on the right side, if you want to change the CO2 or the pH for that patient, then you could increase the number of breaths you give that patient per minute. You could increase their inspiratory pressure, or you can increase their inspiratory time. And I'm not going to go into rise time right now for this. Oxygenation is kind of the same. You adjust the PEEP and the FiO2 for that. And then just like cars where you have gasoline cars and you have electric, you have all these hybrid cars. You have these hybrid modes. So pressure regulated volume control is found on all the expensive ventilators. They name it many different things, but basically you say, okay, I want to try to get 400 or 500 cc tidal volume to this patient. And so the ventilator then in the pressure regulated volume controlled method will say, okay, I'm targeting 500 cc's. I'm going to give this pressure for this amount of time. And then after 1 breath, 2 breaths, or 3 breaths, if that target is not reached, then the ventilator just on its own steps up the pressure with each breath with a goal of either meeting that volume target or running up against the alarm or the control settings that you've set for that patient. SIMV is kind of a mix where you give a patient a certain amount of pressure controlled or a certain amount of volume breaths per minute. And then if the patient goes to take extra breaths, the valve will open and the patient can draw in as much air as they want for those extra breaths. But they get their mandatory breaths, and then the patient can spontaneously breathe in addition to that. And there are many variations of that, but most of us add some pressure support into their spontaneous breaths. So they get pressure supported breaths mixed in with their mandatory breaths. Pressure support is what we call spontaneous breathing. That's where I determine, as the patient, I initiate the breath, and once I trigger the ventilator to deliver that breath, the ventilator then just gives a certain pressure support and allows me to take in as much air, sort of for as long as I want to. And then when it senses my flows have slowed down, it will cycle to exhalation, allowing me to exhale. And then there are other things. This last one is airway pressure release ventilation. It's one of the high-tech modes. A patient can, because of the quality of the exhalation valve, which is very sophisticated, you can pressurize it very high, and then very briefly in every minute it drops down to a low pressure and then immediately resumes the higher pressure. The patient can spontaneously breathe whether they're in the high pressure or the low pressure phase. So they can ventilate spontaneously throughout their cycle, and they also ventilate a little bit as the ventilator cycles from high to low. So that's a lot more complicated than the FCCS course is. If you dropped me anywhere in the world and told me, okay, here's a ventilator that only does one of these modes, I could take care of the patient well with that one mode. So really, you really need to just focus on one mode, learn it well. And so most things, if you just have volume control, you should be able to ventilate any patient, although you might have to resort to tricks and things like that. But one mode alone, you don't need all the fancy modes for most patients. Now, when you look at the national stockpile, I think for the last just couple minutes, I wanted to just mention the ventilators in the national stockpile. There are many potential issues with maintaining those ventilators. A ventilator you just can't put in the closet in the back of your room and forget about it for 6 months and take it out and expect to work. Like anything with batteries in it, like anything with plastic parts in it, the batteries need to be cycled on a regular basis. They need to be maintained. There are parts that break down that need to be replaced. So if you have something in the national stockpile and you don't pay for maintenance contracts and things like that, you may end up with a lot of ventilators in the national stockpile that are non-functioning. We have many ventilators in the national stockpile, which I'll come back to in a minute, but some of the workhorses in it was the LP10, which is this one, the Eagle 754. This is the one military uses a lot. When I was on the Mercy, I did 2 deployments on the Mercy for almost a year underway on her. We had 100 impact ventilators. It is a workhorse ventilator. It's a great ventilator. It's used to transport patients throughout the world. If you go from one hospital to the other, it's a good ventilator to put the patient on to transport them. This is in the national stockpile. It is what you get if someone drops a pallet of ventilators for your hospital that's run out of ventilators. You may get a pallet full of these impact ventilators. It's there are some problems with these. When you looked at New York City during the height of the pandemic, for them, they would get ventilators. I'm not saying their critical care people were high maintenance or anything like that, but an intensivist who's used to using a $90,000 ventilator with very sophisticated graphics where you can look at flow volume loops, very intuitive touch screens and stuff. If you drop one of these ventilators into their midst, it takes time to learn how to use it. And I'll kind of go over a little bit about these ventilators. But I've used the impact once every couple of months for the last 10, 15 years. If you drop it in my lap, it takes me about 20 minutes to look over, to learn how, to remember how to use it, to set it up. And then after that, I'm fine taking care of a patient. But it is much less sophisticated. It can do a lot. It can do almost as much as many of the expensive ventilators. It just takes a lot more knowledge of the knobs and stuff to make that happen. This is the 10, LP10, and then this is another workhorse, the LTV 1200, which is in our national stockpile. And I think I'll come back to this in a second. Now, these ventilators all show up on your doorstep with a quick start guide that's usually like a trifold that opens up. The LTV 1200 has a 12-step how to set it up and put it on your patient and run it. It also comes with a manual that's a couple hundred pages thick that you would have to read and learn about if you've never seen this before. You certainly could get up and running for your patient with just the trifold 12-step start thing. The manual would allow you to answer all your detailed questions. And then these all come with internet access, or there's videos on the internet and stuff that you can look at. And I'm going to show this in a second. Let's see if this will work. So this is just a 4-minute video that is for the LTV. If I can get it to work here. Maybe I'll come back to that in a second, but it's a 4-minute video. And if you look at that 4-minute video, it will show you basically how to take it out of the box, how to set it up, how to hook it up to the patient in 4 minutes, and then how to go through the modes. The LTV 1200 ventilator can do pressure support ventilation, it can do volume ventilation, and it can do pressure control ventilation. It can run off high flow systems, it can run off low flow systems, although generally you want a high flow system because the battery life will last longer. Typically, all the ventilators in the national stockpile should have battery lives of at least 4 hours. They should be able to ventilate adults and children. There's several other things. They should have some basic modes available, but most of the ventilators in the national stockpile historically have been transport ventilators. Now, March 2020, these are some of the examples of the ventilators that were in the national stockpile. I think Asha was working with a group. They just published a paper in Chest. Remember in April, May, a very business-centric working group was put together in Washington, D.C. that placed an order, $3 billion for ventilators to add to the national stockpile. Most of those ventilators were pretty good ventilators. Some of those ventilators were not very good. It was almost 200,000 ventilators. I think it came out to 198,000 ventilator order was placed. And I think around 160 or 150,000 ventilators are planned to be delivered. There are quite a bit more. I know the LTV 1200, I think there were another 22,000 of those ventilators in that order. So from the national stockpile, it's possible that you can get a host of ventilators. Some of the ventilators they ordered are very sophisticated, very good interfaces, that if you dropped into any ICU, most people would be very comfortable using right away. And then a lot of the ventilators in the national stockpile are more basic, more historically transport ventilators, and they would just take a little more sophistication to figure out how to use, although they would work for most patients. Now, the ventilators in the national stockpile are for disasters in general. When you look at conditions that give you COVID pneumonia, give you ARDS syndrome, give you very complex lung injuries, many of the ventilators in the national stockpile just aren't by their nature up to being able to ventilate patients like that. But for most patients with COVID-19, most ventilators in the national stockpile would work just fine. I think that's all I have. I know it's kind of short what I covered, but I just kind of wanted to go over the NIH guidelines. They're really basic, but very solid, very, very good, well thought out. I wanted to review a little bit about oxygenation therapy. I wanted to emphasize the importance of proning patients. And then I wanted to mention a little bit about ventilators, and then also talk a little bit about the national stockpile. Any questions from the group? None?
No, no. Thank you, Scott. This is amazing. I think our heads are swimming, and we really, really appreciate the granularity on this. I put a list in the chat box. So we had emailed the headquarters in Sacramento to ask what was in the warehouse that we had received from the national stockpile. And so we've got, I don't know what the Biomed device TV100 is, but the P Newton is something we still have. I saw boxes of that in Imperial at the first deployment. The ResMed, I'm wondering if that's a sophisticated CPAP. And then the Ventec, the Voxen, and the Viasis. I think those are the two workhorses that I would feel comfortable pulling out of the box. It looks like, let me see, we have lots of thank yous in the chat box.
Yeah, I just jump in for the ventilators. There are some bad eggs in the national stockpile that basically are just CPAP machines and BiPAP machines. In order for speed of getting that order placed, I know they kind of marginalized a lot of the critical care input, and they really focused on the business, what the companies can produce and stuff. But what I would do, if I would find out what ventilator I'm likely to work with, and then very quickly you can just look online, and you can usually find a video anywhere from 4 minutes to 8 minutes that goes over the ventilator in detail. And then I would download, the manual, and then also the quick start guide. But I think for any ventilator, just focus on the one ventilator you're going to learn the basics of it, and just focus on volume ventilation. It's very intimidating up front, but after you've been doing it for 6 hours or 8 hours, you will be the world expert on that. So, you just need a little proctoring and stuff. And once you're up and running, you get very good. I know we talked to one of our colleagues who's at the Leahy Clinic, and she had a bunch of doctors who had very little experience with ventilators. And within a day or two, she kind of had everyone up and running on the ventilators they were using just fine. But they are intimidating. But just looking at the basics up front, knowing the ventilator you're getting, and looking at the book on it is key.
Scott, you mentioned that the Impact is probably the most common ventilator, and also is mostly used for transport. Can it be used for long-term therapeutics, or is it just good enough for transport?
No, it's perfectly fine. It's where you're at in the environment. In the military, we use a lot for our transport ventilators, but you can use it for days and days and days. If you're at like a very small medical facility forward deployed, you may just have an Impact ventilator. in the Philippines, the typhoon, I was there for months there, and the hospital, the regional medical center there just had 2 small impact ventilators. And we ventilate patients for days and days. You just have to be mindful. You have to measure your peak pressures and plateau pressures and just keep them under control. They do have alarms and stuff like that, but they don't have the big displays that I'm most useful to. So I just had to kind of just be more aware of the alarms and stuff. But you can ventilate anyone with any of those ventilators for days and days.
And so if you're not used, obviously you're using ventilators every day. For those of us that don't, the impact might be the best choice.
Yeah, I think that's a basic one. The LTV 1200 is good. And the 3 original ones that are kind of core ones in the strategic stockpile, they're all good ventilators. You just learn the one you're most likely to work with, and you'll be able to support many patients who would otherwise you would not be able to support without a ventilator.
Thank you.
Scott, you had mentioned aerosol generating procedures and the CPAP, BiPAP. We have about 20 patients on oxygen in our ACS, and I think that's our cap for now.
Yeah.
We are looking at putting in CPAP as a rescue for if the EMS systems can't rescue us quickly enough, if they're overwhelmed. Can you comment on its AGP potential? We're all in PPE in the hot zone. So I know, and it's a big gymnasium with lots of ceiling space. Do we really need to be concerned with a short stint on CPAP?
Well, I think it's all relative risk and it's time of exposure. I think the ventilation, you'd have to look at the ventilation. We use BiPAP in secure areas, negative pressure rooms. You know, all our ICU rooms are negative pressure. And then the ER where we use the BiPAP, it's all negative pressure. And if we use it on the wards, our wards are negative pressure also. So if I used it in a gymnasium, it would be in a segregated area. It would be an area that someone has said is airflow away from others, negative pressure. I would use, even when you use biofilters on the BiPAP, though, the seal around their mask and stuff would release aerosolized air into the environment. So it's a little bit of risk. If I had an N95 on and I had PPE and I had head covering and appropriate eye protection, I would personally feel comfortable taking care of that patient. I do realize it's all a graded risk. It's not completely risk-free, but so the original question of non-invasive ventilation in an open area with other patients, I would be very cautious about doing that.
They're all COVID positive patients. So.
Yeah, so if you're all COVID and everyone's wearing PPE, then that's fine.
Great.
But you have to treat that whole area as a contaminated area, right?
It is.
Yeah.
It's all the hot zone. It's all.
Yes. So,
okay.
It is. That's fine if you're wearing PPE.
Yep. Oh, and this is useful, especially for all those on the call right now too, because that may be something we'll be seeing.
Yeah, I mean, there's risk to everything. There's relative risk. But I think I'll echo Ryan's thing. It's like everything in infectious disease, it's prevention is the most important thing. And then so therefore it's PPE. It's recognizing the risk and wearing PPE when it's appropriate. I've always felt safe. You know, I've gotten trained in PPE. I see my patients, I intubate patients and things like that. And with PPE, and following the rules, how to doff and don it properly, I feel safe with that. And I think me as an ICU doctor, my biggest risk of getting COVID is stopping in the gas station or at the store going home. Just talk about, asymptomatic patients. 84-year-old gentleman who I admitted 2 nights ago, he presented because he had burning on urination. So he came in with a heme problem, and in the emergency room, when they checked his saturation, he was satting 70%. And he has severe COVID pneumonia, but he did not come in because of because of respiratory symptoms. He just came in for an unrelated problem. And so that just emphasizes my point is I'm more likely to get COVID in the community from this guy standing next to me in the store or something like that than I am in my ICU when I'm wearing proper PPE.
Agreed. I concur. Melanie has a question regarding PPE and aerosolization and transmission, and that the risk is probably when we touch our face, hands, or our hands to our face. But Melanie, do you want to?
Yeah, no, I read that.
I'm just, you know, we're doing a lot of the doffing, and I understood that in the beginning from infection control, but I've been working in a lot of COVID hotspots in nursing homes, and I just don't really see personally the value of the gowns and the gloves when, you know, what I want to focus on is proper ventilation in the rooms, which I don't think is still talked about enough, because in nursing homes we don't have negative pressure situations. Right. But in terms of the people, those of us who are working there, you know, making sure we wear masks and shields, but do we still need to be wearing all the gowns and the gloves? And, you know, to me, that just seems like I don't know.
Well, I
like your opinion on it.
Yeah, no, it's expensive and it does cost money, but there's a lot of films of aerosolized gas. And when you look at intubating a patient, when you look at bronchoscopy, or you look at a cough patient who coughs in your direction, the aerosol cloud comes up, hits you in the face, and it comes up over and it lands on the back of your head, it lands on your shoulders, it lands on your back. So if you just wear a mask and face covering and eye pro, and you wash your hands when you leave the space, you clean your hands, you sterilize them, and then you're walking down the hall and you brush your back and then kind of wipe your face, you've transmitted the virus. So
do you really do you really feel like it's flicking off of us into the air again?
I think what happens if you look at the aerosolized gas, it's sitting on the back of your shirt, and a minute, 2 minutes later, you brush that, and then you kind of brush your face. It doesn't have to be aerosolized. You can now transmit it to your nose.
I'm not touching my face, obviously, because I've got my mask and my shield on, and I wouldn't touch my face anyway. But I just am not being able to visualize the viral particles on our clothing. Is it being flicked off into the environment? Is it really that? Is that really a study that actually is a mode of transmission?
I think that stuff sitting on a cloth shirt or something generally would not be flicked off into the air again.
Yeah.
Now, I am not the expert on this. I just know from looking at the film of aerosol. But if you take that and you touch it with your hand on your shirt,
Mm-hmm.
and then you bring those particles that were sitting on your shirt to your face, to your nose area, you've gotten it to your respiratory tract now.
Yeah, right. But the point is that you're not touching your face. You're always washing your hands. So I am not ever touching my face.
Yeah.
In that environment. And if
right, but what I'm thinking when I think about this, I think about me 15 minutes later in my office doing this and then touching my face.
I wash my hand. I'm a nurse, so I'm like washing my hands before I go in and out of the rooms. I'm washing my hands constantly in that environment.
Right, but what about 2 hours later when you're sitting there eating dinner, after you've washed your hands for dinner? If you touch no surface and don't touch your face, then you're okay. So it's all relative risk. And it sounds like, frequent hand washing, like Mom told us when we were all little, is the most important thing. Right. But I think certainly the most important thing is wearing the proper mask, wearing the proper eye shield, and washing your hands when you come and leave the room. But you still have particles sitting elsewhere. And if we're like, you're aware of that, and so you don't necessarily do that, but the average person doesn't think about that very long.
And I think that's a good point, is that even though we might not feel like we're going to put ourselves at risk, we're working in an environment with lots of people with lots of different habits. So, I'm willing to put all that on if it helps other people to be more careful around themselves as well. So that's a very good rationale, and I appreciate it. Thank you so much.
Okay.
Can I just add on to that question a little bit? Hi, this is Kathy. I'm one of the nurses, and I was in Imperial with Dr. Devereaux over the last weekend. And I've worked in quite a few pandemic and epidemic environments before, mostly in other countries. And one thing that we often see there is an outbreak on top of a pandemic. So often it's of a diarrheal illness. And so I think one thing that I saw in the hot zone is there was so much focus, sort of like Melanie was talking about, on like the gowns and gloves, and not changing the gloves and not opening your hands up at all, and kind of just using alcohol over the gloves and things like this. And I fear that that eventually is going to turn into a different type of infection control problem. So I'm just kind of putting that out there for folks who are going to the ACS sites to maybe think about putting some hand washing stations inside the hot zone, and really encouraging folks to be able to wash their hands and change their gloves appropriately, particularly if they're helping patients up to the bathroom and helping them with daily care activities. I think too much of an emphasis of, not having anything exposed can actually have a really negative effect sometimes. So just throwing that out there.
Kathy, that's an excellent point, and something that we can easily bring up the chain of command to put in hand washing stations inside the hot zone for staff. And also listening to Dr. Parrish, the head coverings, we don't have that, but after when I'm doffing, I take the sanitizer wipes and wipe it across the top of my head, but that's not on the instruction sheet. But I don't think we have the head coverings. None of us, very few have gotten sick after hundreds of people have mobilized, though. So there could be an argument made.
Yeah, and I don't know all the specifics of that. I know, obviously, if you hand wash, don't touch your face. That's extremely important. And after you've worked, if you, properly shower, change your clothes before you leave that environment, that's all good stuff. Anything to reduce the surface contamination. And it's, we're an extremely resource-rich country, despite what anyone may tell you. Certainly, when you go to resource-poor countries, just having one pair of gloves a day is a stretch for many healthcare providers. Much less gowns and things like that.
Does anyone else have any questions?
Dr. Devereaux, I just wanted to find out, so are you saying we don't have head coverings at the surge sites for the ACS sites? What is the PPE that they use right now?
So we currently have gowns, gloves, shields. We put in a request, some had put in a request for booties, but we've got bleach for the shoes because taking on and off the foot covering can actually cause your hands to then get contaminated. And then we also have, the wipes, and we have some peppers, and I think they're going to order some more.
Yeah, I think what Dr. Parrish was saying earlier, especially with the cloud
Yes.
on the back, I've seen that. I've read a lot of papers on the way it's transmitted, and I think head coverings would really be beneficial, specifically if we're going to be in a gym, studio, sort of, or a huge area, and there's lots of COVID patients at the same time. I think that would be beneficial to have if that's the type of site that we have.
Yeah, I think if you go to the NIH website and look specifically, because a lot of my concern with the cloud and stuff, that's an aerosol generating procedure like a bronchoscopy or an intubation. That's like the biggest thing. But if patients are not, if you just go in to see a patient, check their vitals and things like that, examine a patient, then it's an N95 mask, it's iPro gloves, but
we're considering having CPAPs and BiPAPs. And with that, we are kind of having a risk of having aerosolization of the virus in a huge setting. So
yeah, and I'm out of my lane for that, and that's why I would just refer you back to like the standard NIH guideline. Just go back to that and see what they say for that situation and stick with that.
thank you.
Well, I thank you, Scott, and really another round of gratitude to Ryan as well. I know you have taken time out of the ICU for us, but you have definitely helped us be a force multiplier so that hopefully not as many folks land in the ICUs and create more work for you. We thank you so much. This video recording will be transmitted to state, and we've also received requests for your slides if you and Ryan don't mind sharing, and we can do that offline.
Okay, no problems.
Well, thank you again. And
all right, thanks. I have to go save Jonas.
Yes,
He
I know.
gave me
Stay
2 hours
safe.
of his life, so I have to.
Stay
All right.
safe. Take
Okay,
care.
thanks. Bye.
And to everyone else, thank you for participating. Finish up the FCCS course, and more to follow. Have a good weekend, everyone.
Thank you.